Joining me in the studio from Advanced Rehab and Sports Medicine, it is Clinic Manager Doug Price. Good morning, Doug.
How are you?
Good. How about you?
I'm good. I blew in here today. It is a little gusty out there.
Yeah, we sure have seemed to have a lot of wind this spring.
Yeah, I'm tired of picking up sticks and pine cones in my yard. But
Sticks and pine cones. Do you get the allergies too?
No, I don't have any problem with that.
Oh, good for you.
I'm blessed on that front. So
good for you. Some people are really getting the allergies.
Yep.
How are things at the clinic?
Clinic is good. Again, just always encourage people that if you haven't stopped by for a while, just to say hi. If you've never seen the place, you can come out and take a look at it and whatever. But we're always welcome to have new customers.
Okay, tell people where you're located.
We're at 1201 East Broadway. If you know where that new park is with the little splash pad, we're right across the street from that.
Okay. Today we're going to talk about knees.
Do you know anything about the knee?
I do. It's called
How are your knees, by the way?
Too many years of basketball. I'll say that.
Yes. Too many. Now, you've probably had some surgeries as well, too.
2 scopes, yes.
Yeah. So I thought we'd kind of get into the knee because there's always a lot of questions kind of surrounding the knee. That's usually, one of the main things we see. The back is always kind of the back, knees, and shoulders are kind of our bread and butter. I mean, we see everything. As you know, we treat everything from vertigo to balance stuff to any kind of post-surgical stuff. But, there's kind of the top 3 that people always have issues with. And the knee is certainly one of them. So I thought we'd kind of get in and talk about what the knee has in it anatomy-wise, and then kind of what some common injuries are and when to have surgery and all that good stuff.
All right. Tell us all about it, Doug.
So the knee, basically, within the knee, you always hear the term like, I've worn out my cartilage. Like, what does that really mean? So within the knee, there are 2 little things called the meniscus. You have a medial and a lateral meniscus, meaning the inside of your knee and the outside of your knee. And these basically look like kind of like a C-shaped, if you've ever had any oysters or anything like that, it's kind of like this little cushiony kind of pad. And it's not much. But it does provide a little bit of cushion in there, and this is what a lot of people will tear. I've torn my meniscus or anything like that. So if you have done that, then they can go in and kind of fix that, trim that up, remove it completely. But so the meniscus, they're there to absorb some of the shock. But the good part is it's even if you lose some of your meniscus, or in my case, all the meniscus, then you can still function. And this is where the muscles come into play, which is why I'm always kind of promoting, hey, you need to make sure you're doing good, staying consistent with your exercises, get some good strengthening going on, because the muscles are really the big players as far as shock absorbers for the knee. There's all kinds of different studies out there. Some will say that the meniscus provide maybe 25% of the shock absorber, where the muscles do the rest of the 75%. So that's part of it. Then you have, obviously, your ACL and your PCL. So that means anterior cruciate ligament and the posterior cruciate ligament. That kind of helps with that forward and back translation. So you've heard the most common one is the ACL. People, I tore my ACL. Usually it's almost like a hyperextension injury, or what you see a lot, especially in girls' sports like basketball, is if you come to a sudden stop, but yet the body kind of keeps going, so that femur or the upper leg kind of keeps going and translates, and that's where they can get a kind of that shear and tear that ACL. In football, you can get it from obviously getting hit and it hyperextends and you tear your ACL. But they're there to help kind of keep that knee stabilized. Any ligament it's their job is to hold that stable and not give. Well, you can only do so much when certain forces hit you. So. And then the other things are the medial and lateral collateral ligaments. So these are on the inside and outside of your leg. So right on the very inside and the very outside. It borders the leg. So it provides, like if I get hit from the outside and it pushes my knee in towards my other knee, that's when you're going to maybe have some damage to your medial collateral ligament, also known as the MCL. We shorten all these things because no one wants to say the mouthful of things. And then obviously if you get hit from the inside of your knee with the force pushing the knee outward, then you can tear the lateral collateral. So those are the kind of the main players of the knee. So your medial and lateral collateral ligaments, your medial and lateral meniscus, and then your ACL and PCL. So that's kind of makes up the anatomy of what's going on with the knee. So the most common injuries then is basically, the meniscus is probably one of the most common one torn, because you can get that with a rotation. So if you're a golfer and you if you go into complete extension, so your knee is straight and then you do this twist, that's where you're going to be most prone to tear those meniscus, basically. And you can get these little, what's called a bucket handle tear in there. And the nice thing with that is that it's a lot of times you don't need surgery, but if it continues to bother and you ache and stuff like that, then yeah, they can go in and I'm sure was that your case? Did you have some meniscus injury in your knees? Or?
Pieces squeezed out literally of the knee, and we're floating in the joint space.
Mm-hmm.
Yes.
So basically they go in and they kind of do a scope, which is very non-invasive. You just get in there. You don't have to really cut into there. They just do a little bit where they get just enough to get the scope in there, and they can trim that up. And usually you're going and back going within, it varies for everybody, but sometimes 4 weeks to 2 or 3 months kind of thing, and you can get back to basically everything you were doing prior to that. So. But then, as I mentioned before, probably the ACL and then the MCL are the other ones that get torn with various weekend warrior type stuff or your sports, that type of stuff. And then those you're dealing with a little bit longer time. I mean, anytime you start getting ligaments into it, if you've ever sprained your ankle, you've played sports, so I'm sure you've probably sprained your ankle. Ligamentous stuff just takes a long time to heal, meaning you can still do stuff on it depending on the degree of the sprain, but it can take sometimes 10 to 14 to so weeks. That's why some people go, it's almost better to break a bone versus really sprain a ligament back, because the bone will heal fairly quick, but ligaments just take forever and ever. There's different degrees of sprains. Like you can have a 1, 2, or 3. So 1 is just like you just irritated just a little bit, where 3, and then you get where you start talking, you've torn it, So then you got to figure out, okay, do I need surgery or what are we going to do with that? But same kind of stuff with that. They can go in a lot of times with a scope with some of these things. They got to do a little incision now for the ACL, but most of the time people do really, really well with all that. Just the ligament just has a little bit longer rehab process with that.
Okay. How do you know when to have surgery?
Well, it's like in the meniscus case, if something has, you've done your therapy, you've done all this conservative stuff to try to get it better, but yet you still have this nagging kind of aching sensation, or you just can't get your range of motion back, pain is still present, and you've done you've done injections. That generally what they'll do anymore before they even do an MRI is your insurance company is going to say, well, we want you to do physical therapy and all this good stuff. So because an X-ray is not really going to show anything, you're going to need MRI if you're going to actually see what ligamentous damage is there. If there's a meniscal damage in there, you're going to need an MRI to do that. But those aren't cheap, unfortunately. So basically, they say you need to do therapy, because a lot of times therapy will help that out. Meaning you're like, oh, you know what? It was bothering me, but now it's pretty good. I'm back to doing pretty much everything. I got my strength back, stuff like that. So a lot of times you don't need the MRI. But if it's still bothering you even after injections and physical therapy, and it's still aching, then it's time to maybe consider surgery with that.
All right. So talk to me a little bit about, you're hearing a lot of knee replacements.
Correct.
But you're starting to hear more ads, more podcasts about PRP therapy and stem cell therapy. Do we know anything clinically, any studies about this?
Well, it's still, it's been around longer than people realize, but there's a lot of research to be done, and not everybody's on board with it, meaning the insurance companies, it's just a kind of a costly thing. And unfortunately, that's what drives the whole business. So until insurance companies get on board with stem cell stuff, then it's just not going to be widely used. So then they're still going to go more the replacement route. You know what I mean? So that's still, and there's nothing wrong with that, because people do fantastic with replacements. And replacements, back when I started, they would tell you, you're going to be good if you get 15 years out of it, So that's why they always would push, like, hey, you need to push this off for as long as you can, because you might only have 15 years of this knee replacement. Well, now they're getting close to 30 years out of these things. So, if you're, someone like me who's had 2 scopes on each knee, all I'm trying to do is I'm trying to keep myself as healthy for as long as possible. And that's all we're all trying to do, is just trying to keep joint health as good as we can, try to keep our strength up. But at some point in time, I will have to have my knees replaced. So, that's a pretty good bet. I'm in my 50s now, and if they last 30 years, that's, you do the math, that's going to be pretty good. That's not obviously a guarantee, but But people do really well and really get back to pretty much normal kind of day-to-day life on that. You lose a little bit of being able to kneel for long periods of time, or you really shouldn't be on them, kneeling on them for a long period of time, and like deep squatting, but you had probably lost that anyway.
Oh, yeah. Giving the dog a bath is quite a unique experience with our knees, right, Doug?
Yes, exactly. You find creative ways to do that. But
yes.
But I think everybody always, you always hear for so many years that, hey, you need to put this off for as long as possible until you can't stand it anymore. And while I would agree with that, but what I always kind of put on top of that is if you start to lose range of motion in that knee, then you need to have it replaced. So meaning if you can't get it completely straight, or if you start to say, man, I can only bend my knee to 90 degrees or whatever, then it's time to don't let that go forever, because now the muscles are shortening. And what happens then, so they go and replace this knee, and the knee, like a new knee replacement, will bend to about 125 degrees. Okay, that's the goal. That's what it's designed to do. But if you, for the last 3 years, have only had 90 degrees of motion, the muscles have tightened up, they'll replace that knee, and under anesthesia, you'll have like, oh yeah, it moves to 125 degrees. But you wake up, and that muscle goes right back to that same muscle memory of, I'm not going to let you go any further than 90 degrees. So it's difficult, and the rehab's difficult if you start to lose a lot of range of motion. So I tell people, okay, yeah, you need to go as long as you can, as far as before you replace it, regarding taking as much pain as you can. But then also, but if you start losing that range of motion, then you need to get it done, because it's just going to make your life a lot easier. It's going to make rehab go that much better with that. So that's kind of the other caveat that I kind of say along with the replacements. And so many people that are just, I get it. It's a big deal. You're replacing a joint in your body, but so many people get really kind of terrified and have a lot of anxiety about replacing the knees, but people do really good with it. I mean, a high percentage do extremely well. So
how many have you seen on average now? Replacements, hips, knees, shoulders. You've been doing this a while.
I've been doing this 33 years, and I thought when I would start out, it'd be kind of cool to keep a stat of how many knees I've seen, but I didn't, because it's just thousands upon thousands. I mean, just yesterday I had 4 knee replacements in a row, just as a patient. That's just in one day kind of thing. So it's been thousands and thousands. It'd be a little frightful to see how many just hip replacements and knee replacements, shoulder replacements, all those kind of things that I've seen over time. So when I tell you that they do well, I've certainly seen my average. I'm not an orthopedic surgeon, so I can tell you, obviously they're going to go like, yeah, you'll do great, because that's their business, But my business is just to get you back to doing what you want to do.
Gotcha.
So, I'm going to tell you either, and I've told people like, yeah, I wouldn't do that if I were you, or I wouldn't have that surgery, or so on. So, like I said, years ago, I used to tell people not to get their shoulder replaced, because it wasn't good. I mean, the only reason you should get it replaced is if you couldn't stand the pain anymore. But now it's phenomenal what they're doing with these shoulders. They get close to full range of motion back. They have good strength. I mean, all these things. So it just depends. So how science and technology and everything has done with that. But yeah, knees do wonderful. They're a little more uncomfortable to replace than, say, the hip, because the hip has this large musculature around it than where the knees don't. But they still do well.
Okay. And you hear about the term partial replacement. What does that really mean?
They were doing that for years. So basically, the inside of your knee is the area that wears out the quickest. So the medial compartment of your knee is where most pain is, and it's just because of how we're built. So what they were doing is, so they'd look at it and they go, well, the lateral aspect of your knee still looks good. I mean, the cartilage still looks good in there, but the medial side's horrible. So they were just going in and just kind of replacing just that inside, that medial portion of that knee, and they did well, but then they found that it's okay. So after a while, then now that lateral starts to wear out, and like, why put someone through in another 5 years when they might need another kind of something with that? So they've just, with the longevity again of these complete total knee replacement, they're like, yeah, this is going to last you for close to 30 years. So just go ahead and do it rather than do another major surgery.
We're talking with Doug Price, clinic manager at Advanced Rehab and Sports Medicine, about the anatomy of the knee. So anything else you want people to know about the knee today?
I did kind of leave out articular cartilage. So articular cartilage is it's like a helmet. It's around at the end of a joint, on any joint. So it's smooth cartilage. It's there to take that impact, okay? Because bone, if we all know that when we hit our shin on something, it's very tender. Well, the end of your bone is not like that because it has articular cartilage around it. It's just really hard cartilage. So when you hear the term bone on bone, that means that articular cartilage has started to wear down and kind of you're wearing through that, and you start to get divots in it and just areas where you've now got to where it's touching bone. So bone on top of bone, and that's where it gets really sensitive, and that's why we get all this pain, and which eventually leads you to having your knee replaced. So that's kind of just when you've ever heard the term bone on bone, that's kind of what they're saying. But
when your knee looks like a potato?
Yeah, that's not good generally. When you got all these things floating around, or when you hear just because you have a lot of noise when you squat down doesn't mean that you need to have a surgery on it, but that does mean you're wearing down some of that cartilage, and that's what's floating around in there. And now you hear that kind of like, or if you ever gets louder and I've heard some loud knees like when people bend over, I'm like, ooh, you're rubbing basically bone on bone with that kind of stuff.
Which little fragments have to be eventually coming off of that, you would think.
Yes, exactly.
Little bone spurs,
and that's what's floating around in there.
Yes.
So when they say we're going to go and clean that up, that's what they mean. They're going to clean up all that stuff just kind of floating around in there that maybe is kind of causing some stuff, and just kind of clean that up and see how that does. But, yeah.
But if your knee looks like a potato.
Yeah, it's not necessarily what you're going for, but.
No. Okay, Doug, anything else you want people to know today?
So the biggest thing is don't put off. I've always said this, don't put off things. If you've been having pain for longer than 2 weeks, I don't care what kind of pain you're talking about, anywhere in your body, you probably need to have it looked at, and it's not just going to, quote unquote, go away. So give us a call because we have direct access, which means you do not have to see a doctor. You can come directly to us. Give us a call. We can schedule an appointment and evaluate you and see if we feel that you would benefit from physical therapy.
Okay, fantastic. Thank you so much.
Always a pleasure.
Doug Price with us, clinic manager, advanced rehab and sports medicine.